For those of you who are not here in person, we are in a very nice, fancy boardroom that has two kind of witness stands in front of us. So if you were here, we could make you sit at the witness stand and pretend like we're going to interrogate you. All right, Dr. Rice, I think we are ready to go.
All right, perfect. Good morning, everybody. We'll go ahead and call the meeting to order. We'll have Shelley start with the roll call, if she's ready.
Just a couple of housekeeping items too. We are recording this meeting, so anything said in the chat box or verbally or anything viewed via webcam will be recorded and posted to our website. Julie and I will monitor the chat box for questions. For everyone's benefit, if you could please state your name before making your remarks, that helps everybody. And then if you're having trouble getting unmuted and you're on phone only, hit *6. That should unmute your phone on your handset there. Thank you for your participation and patience. And the roll call, I'm going to start with Amber Rice. Here. And Brian, next is Brian Smith.
Present.
Next, Chester Key, are you on the call?
Present on call.
Ed Mazulis, are you on the call? Josh Gaither.
Present.
Chris Ramos.
Present.
I saw him trying. I saw him. Is he on?
Present. Can you guys hear me?
I heard something faint. You're really quiet, Chris. I think we're hearing you in the background.
I'm present.
Thank you. Christina Long. Matt Shaw. Orlando Alcordo.
Present.
Ryan Harold.
Present.
Sandy Nygaard.
Present.
Sharon Hollingsworth.
Present.
Phoebe Merrill.
Present.
I count 10. We do have quorum.
Great, thank you, Shelley. We'll go on next with the chairman's report. Two small items. There is the committee attendance report as one of the attachments, 3A. As a reminder, if you missed 2 consecutive meetings, the Bureau will contact you and ask if you're still interested in serving on the committee. There aren't any vacancies at this time. And the other attachment will be the 2022 Statutory Standing Committee meeting schedule. So that's also in the packet as well. Any questions on either of those? Great, so we'll move on to the Bureau report. We'll start with you, Chief Garcia.
All right, good morning, Dr. Rice and committee members. I'll go ahead and share some updates. The state budget has been approved. The Bureau's budget this year has been approved for a slight increase, but actual funding is expected to remain relatively level this year compared to recent years. The Bureau still has several vacancies posted on our state jobs website, including a position for education and training. In the last month, we've welcomed new hire Travis Connors as a project coordinator within the Bureau. He joins us today and he'll provide a brief introduction after we finish some updates. Arizona's reached a new milestone in pandemic recovery and our response. I'm sure you've all heard the governor's rescinded several COVID-19 related executive orders. The emergency declaration remains in place. Currently, executive orders implementing enhanced surveillance and the surge line also remain in effect. And the department continues to monitor cases through hospital and lab reporting and still recommends vaccination as the best form of protection against the variants that have been detected in Arizona. The Bureau is also working closely with ADHS licensing to update a current policy statement on the use of EMCTs in hospital settings. With the licensing of hospital at home programs on the heels of the pandemic, we expect the use of paramedics and EMCPs in these programs to follow the same guidance as the traditional hospital settings. That would include requirements for scope of practice and medical direction. The department also continues the regular rulemaking process for ground and air ambulance rules. We have new drafts of both air ambulance and ground ambulance rules available for comment on the azhealth.gov website. Those will be open for comment through August. The informal draft process for both air and ground ambulance rules is expected to continue through 2021 with plenty of opportunities for comments before moving forward to the formal process. EMS scope of practice is still pending. We have an update recommended by the Medical Direction Commission that's been sent over to the governor's office, and we are still waiting to hear back. Scope of practice follows exempt rulemaking, and we would expect adoption of these recommendations this year, although we want to note that we have several requests still pending at this time. I believe that is all I have for now, pending any questions.
Any questions for Chief Garcia? Okay, great. Next on, we'll hear from one of our new Bureau staff, Travis Connors.
Hi, everybody. Can you hear me?
Yes.
Hi, so this is Travis. I am joining from the medical marijuana program with the Arizona Department of Health Services. I am an MPH graduate from the University of Arizona. I'm coming over to be the project coordinator for the Bureau. Now, one quick update I wanted to provide everybody is we did switch to the electronic digital card certification. So we are effective July 1st of 2021, the Bureau transitioned to a fully online EMCT certification process, which included the issuance of digital certification cards. We have that bulleted to our homepage as well as the EMCT certification homepage as well. We updated our frequently asked questions. So starting on page 6, there will be screenshots and a description of how you can access your EMCT digital certification card. If you have any questions, you can feel free to reach out to me, as well as provide any feedback. We're always looking for ways to engage with our stakeholders to make our information better usable for the external user. My email address is Travis, Travis, Connors, Connors, @azdhs.gov. Thank you.
Thank you, Travis. The next thing we'll have is an update on the naloxone Leave Behind program from Dr. Bradley.
All right, good morning, everyone. I know some of you were on the last meeting. We really wanted to make sure that we spread the word about the naloxone Leave Behind option within Arizona. I'm sure everyone is aware, both within the state as well as nationally, we have seen an increase in the number of opioid overdoses and deaths, and these numbers increased significantly during COVID. So with 2020 data now being analyzed, we are starting to see that there has been an uptick in those numbers. The initial statute that allowed for EMTs to administer naloxone along with law enforcement, that was from 2017, also gave EMS the ability to do Leave Behind naloxone. And so when this topic first came up, I think for people who aren't familiar, they weren't really sure what that means, but it essentially allows EMS to distribute naloxone. So with your agency's administrative medical director's approval, you have the option to actually administer naloxone and give it to whether it be the patient, bystanders, family, friends, anyone who is deemed to be potentially at risk for an opioid overdose. So we really wanted to make sure that we got that messaging out there. This committee today will be reviewing the training PowerPoint that was put together. And so this will be part of a package that we'd like to make available for EMS agencies. In addition, any agency that would like to go live with naloxone Leave Behind, the Office of Injury Prevention does have the opportunity that you can request free naloxone. This is the commercially packaged 4 milligram dose of the intranasal naloxone. It comes in a package of 2. So that is available free through the Office of Injury Prevention. So we are going to be sharing this message quite a bit. This is something you probably will hear for several times over. If you have any questions about this, if you are an EMT only agency and you do not have medical direction, there is a standing order under my name across the state that you can use to administer naloxone. and as well as to distribute it in your community. So please let me know if you have any questions now. Otherwise, we can move along the agenda, but I just wanted to make sure we keep spreading that word.
Thank you very much, Dr. Bradley. Next, we're going to have Julia that will give us some updates on SHARE and the EMS for Children program.
Good morning, everybody. A couple of updates on SHARE. The Bureau is currently in the process of recollecting documents from cardiac receiving centers and referral centers. The messaging has been sent out to all centers, just requesting that you submit some documents that have always been the requirements for receiving and referral centers. Additionally, Bruce Barnhart and the AEMRC are currently in the process of drafting the SHARE report for all of the hospitals and agencies that participate in SHARE, and so they are missing some status records, and so they're currently reaching out to those hospitals as well. Dr. Bradley, did you want to add anything for SHARE?
Sure, thank you. So I know there have been some questions regarding this request for information. Any facility that requested or applied initially to be a cardiac receiving or referral center had to demonstrate that they met all these criteria. And so this recognition was started over a decade ago. And over the course of time, some facilities have joined the program, but we've never really circled back to ensure that hospitals still have all these policies and protocols in place. Just like any other program, whether it be CHESPIN accreditation, AFib, ACS, it's customary to do some type of regular review just to ensure that you still have your policies and protocols in place. So I think with turnovers that happen in over a decade, we've had some questions from facilities saying, why do we have to demonstrate that we have these policies? And again, that is part of that recognition process. So moving forward, we aim on having this on a regular cycle where you will be requested to submit these documents just so that we have a good record. As a reminder, this program allows EMS agencies to bypass their closest hospital to bring your facility a cardiac arrest patient. And so we really want to make sure that you have all the policies and protocols in place to provide the best care. So any questions about that, please let us know. I know we have been fielding some questions and concerns about why are we suddenly asking for this. And it's simply a housekeeping piece to ensure we have good record keeping. Any questions from me on that piece? All right, thank you. Back to Julia.
Okay, a couple of updates for EMS for Children. We're currently in the process of conducting the National Pediatric Readiness Assessment. We currently have 26 hospitals that have participated and would hope for more. They did just extend the deadline for that to August 31st. So if you work in a hospital emergency department or know anybody who does, please encourage them to participate in that. We have chosen an EMS for Children coordinator. They will be starting in September. We also, later down in the agenda for this meeting, we have developed some questions to accompany the tracheostomy management training that we developed last meeting. So hopefully those will be approved so we can post those on our website. Lastly, we have applied for some additional funding for EMS for Children, and we'll keep you posted on that. That's all.
Great, thank you very much. Are there any questions for Julia on the EMS for Children? Okay, if not, we'll go to Vassal for some updates on the data dashboard.
Good morning, everyone. We have updated our dashboards based on the current data available to us. So if you see on our dashboard page, we have trauma-related several dashboards, and then there is an EMS dashboard. Trauma injuries by year is kind of gives an overview of trauma injuries in the state of Arizona. So kind of what our annual report is, but a part of our annual report, I would say. And then we deep dive into two main of injuries, motor vehicle traffic accidents and falls. These are the top two mechanisms of injury in the state of Arizona. So then it goes into detail about both the injuries. Also, you will see there is a trauma injuries by race and ethnic differences, and that's another dashboard. So if it gives an overall picture, compares each race and ethnicity with another. And we have an EMS incidents by year. That's our EMS dashboard using our easy peers registry, and gives an overall picture of easy peers and then the data collection, what we do and how many agencies are there, and the 911 call volume, what are the primary impressions and stuff like that. And this has been now, all the data dashboards are updated with the new year, and now we just recently have now 2020 data received for the trauma. So it will again pretty soon in we will update again the dashboards to reflect 2020 data too. That's about it. We do have plans to add more dashboards. One of the dashboards which I'm working on is a traumatic brain injury, so that will be added pretty soon. But if there is any other ideas, any other suggestions for, with the dashboards, please let us know. Thank you.
Thank you, Vatsal, very much. The last item I have is about the digital certifications, which was already mentioned. Did you have anything else to add on that, Dr. Bradley? No? Okay. Thank you. All right, so moving on to our discussion and action items. The first thing is to discuss and approve the minutes from the March meeting. So if you guys can take a look at the minutes in your packet, and whenever you're ready, I will accept a motion to approve them.
Motion to approve the minutes, Brian.
Thank you, Brian.
Second, Sandy.
All right, we'll call for a vote. All those in favor of accepting the minutes as presented in the packet, say aye.
Aye.
Aye. Aye.
Any opposed? Great, the minutes pass. The next one I have is to discuss and approve the post-test questions from the PEDS Trait Management, and that's your attachment B. Julia, did you have anything to add about the post-test questions specifically?
Nothing specific to add, just a note that they are meant to accompany the training that was developed at the last meeting.
So at the last education meeting, we approved the tracheostomy training, and these are the post-test questions that would accompany that training. So are there any questions or discussion on this set of questions? If not, is there anyone that would like to make a motion to approve these?
So moved, Brian.
Sharon Hollingsworth seconds it.
So, one possible friendly amendment just to consider. I just saw with question number 2, there's an abbreviation that I would need to look up. I don't know if we would like to consider spelling that out on there.
Oh, children in special health training.
Yes, please. Thank you.
So those are the 2 pediatricians?
Yes, we love acronyms, but I figured CPR I'm good with, EMCT, but that one I had no idea.
Great. So I have an amendment and a call and 2 motions to approve. I think we would just need to call for a vote accepting this amendment, as Dr. Bradley stated, to expand the acronym to children with special healthcare needs. So all in favor of accepting this training with that amendment, say aye.
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 And then any opposed? Great, that motion passes as well. Thank you very much for your work on that, Julia. The next action item I have here is to discuss, amend and approve the Leave Behind Naloxone training draft. So you'll see it in the attachments here. Shelley will kind of scroll through the PowerPoint. This PowerPoint presentation was developed by the work group to be able to use for an EMS agency wishing to implement a Leave Behind Naloxone program. So in here, you'll see information about substance use disorders, opioid use disorders, some statistics about opioid overdoses in general, talking about EMS involvement and some state and national statistics. And then talking a little bit about harm reduction And then in the back will be the sort of references to the standing orders available, Arizona statute references, and then additionally in there the leave behind guidelines. So is there any discussion about the training? I prefer to sort of open the floor to comments.
You get a motion to approve, people can bring up their amendments.
Yeah, so we have a motion to discuss this. So moved. Thank you.
Right here, Josh, for a motion, and is there a second?
Do I have a second to discuss the training program for Leave Behind Naloxone?
I'll second it. This is Sandy.
Thank you, Sandy. Is there anything you wanted to say about putting this together?
No, I think a big thank you to Dr. Melody Glenn from Southern Arizona, who had initially put together the training. I then have also kind of utilized putting this together and recently used this version preemptively to do some training just to see and felt like it accomplished what we needed to get across with this type of program. It really does change the mentality away from simply, here we're treating the overdose and they're done, but really trying to get to the bottom of how we are kind of in this opioid epidemic. So I think it's really easy to administer and hopefully would be utilized. But again, this is part of that package we want to make readily available so it's very easy for any agency to implement this. Hopefully you guys can hear on the phone, we've got the train back. I don't know if you've missed that train, if you've participated for years in the Bureau meetings, those would periodically make their appearance. So the train is going by. Anyhow, that is the background on the training. So thank you to the work group that helped to get this finalized for today's committee.
This is a fairly comprehensive packet, so it has a lot of information in there, hopefully.
We haven't updated.
What Shelley's referring to is just the standing order that's getting updated. But other than that, in terms of the PowerPoint, it should be ready to go.
Mm-hmm.
The idea with this, the idea with this is that if I, as a medical director, wanted to do a program, I could take this and select the parts. It's not a prescriptive program, but rather a resource.
Correct, yes. Yep, completely voluntary resource, just to kind of hopefully make it easy so that if someone wants to implement this, they don't have to develop their own training. They could download this, potentially adjust it. We did create, there's also the educational pamphlet. So that's one of the things that we've left it with some statewide resources, and then each entity could put in kind of their region-specific resources in the pamphlet to go out with naloxone as well.
Yeah, I think we talked about certain medical directors or certain people who would be giving the training might be more or less familiar discussing things such as medication-assisted treatment or some of those other concepts, so that this would provide a little bit more information in those areas that people might feel less comfortable delivering education on. So, and if you felt more comfortable, you certainly could, amend it. Any other questions, comments, motions to approve?
So moved, Brian.
Motion to approve.
Second, Orlando.
All right, with two motions, I will take it to a vote. So all those in favor of accepting the naloxone leave behind training module, say aye.
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 Are there any opposed? Okay.
It looks like Chris Ramos has his hand up. Oh,
Chris, did you have something?
It was answered, disregard, sorry.
You bumped it. Oh. I frequently do that. Next on the agenda will be the care of the MCS patient. So this is our VAD patient, and so this is going to be attachment D. So if I can get a motion to discuss this item next.
So move. This is Ryan.
Thank you. Brian Harold.
Second, Sandy.
Thank you, Sandy, very much. This update took the original VAD work group training that was developed, came back with a group of the VAD Center participants as well. They had some great input. One thing that they do say is that not all of their MCS patients are VAD patients. So you'll see that some of the verbiage has changed from using the word VAD to using MCS throughout some of it. As an overview, overall, the training has been somewhat shortened due to the links and some of the redundancy in the additional education. So as you go through there, you'll see some information. Most of it's about the LVADs, since they tend to be the more prevalent. Some information about the different components of VADs. How to do the VAD patient assessment. So this one, this slightly updated slide, looking at the patient assessment part of it. There's a graph in there about vital signs and blood pressure.
No, it's like you're on.
I'm on the vital signs slide. I'm just kind of like going through and highlighting things I know are different. I don't know what number it is. But a little bit more about the patient assessment, talking about the different complications potentially in VAD patients. And then really continuing to emphasize that with all of these patients, they're very difficult to treat if they're sick. And so to call the VAD coordinator right away really is the primary treatment. We added some stuff in here about strokes and stroke assessment. So if you look at the section that starts with common 911 calls, the group thought that they should highlight really the most common reasons you'd be called to a VAD patient. So that would include stroke, heart failure, exacerbations, falls, and equipment failures, which are actually quite rare. So it talks about doing stroke assessment in VAD centers. And the key points of this one being going to the VAD center, not the closest stroke center necessarily. Heart failure as well. Some of this was changed slightly just to emphasize doing treatments such as giving fluid boluses in conjunction with VAD center coordination, because some of these patients can be harmed by too much fluid. Falls and trauma. And then cut out quite a bit some of the stuff on equipment failure. The VAD center participants felt that this was a very rare thing to happen, so we didn't want to belabor the equipment failure piece terribly. Looking at the alarms, there's a little bit of addition, learning how to look at the screen for alarms to relay that information to the VAD coordinator. And then the slide that you'll see, if you go down a couple more.
Hi, it's Brian.
Yes, Brian.
Can you back up to that slide just before this? There's, I think, a...
Sure. Yep. What's the top of the slide? Which slide, Brian?
Well,
It's 26.
that one right there.
That
The
one, okay.
The one you just went to after this one. I think it's the next one down there. Chronic heart disease should be heart. Right there, first bullet point.
Oh, is there a typo?
Yeah.
Oh, thank you, Brian. We'll fix that one. Thank you. And then one sort of fairly significant change, if you guys remember the old version, which had a fairly large and complemented workflow, that was changed pretty significantly to this one. So instead of having that big flow sheet where it had a whole bunch of different ways to go, this has really been broken down to so either the pump is on or the pump is not on. So there's one for the LVAD. So this first one is for the LVAD emergency response, talking about calling the coordinator always first to determine if there's anything to do. And then if the pump isn't running, following CPR or following ACLS guidelines for medication administration and things like that. And defibrillation being okay. And when CPR is okay, which is rarely indicated. And then there was a little bit of a section that was added additionally about total artificial hearts. So after the LVAD, there's a little bit of information. This slide was in there before, the VAD versus TAH. We left this information in, sort of the differences between a VAD and a total artificial heart. And then the same kind of workflow for the total artificial heart, very similar. Obviously highlighting that we don't do chest compressions ever on a total artificial heart. And added in that piece to call the base hospital for termination, just as a reminder that this would likely fall outside of the standing orders for most agencies to terminate. But if the pump isn't running, their total artificial heart is not running, they will only live for a minute. So there's not much you can do. And then that was the end of that training. So are there any specific questions?
So I just, big thank you to Amber for helping to shepherd this group. We had very good participation from all the VAD centers, again, within Arizona. They had helped do the initial training, and many of them have been using that to teach EMS, and that was what they used to kind of change this PowerPoint. They really felt like they had some good additions and changes, wanted to simplify it and shorten it. So a big thank you to all the VAD centers for helping to participate in this training. It always helps us when we hear from people who use the training PowerPoints to see how we can improve them. And they also had recommended that total artificial hearts have really started to increase and to try to separate those out. So the last round of meetings with MDC did approve a total artificial heart TTTG, which was new, and that was added in specifically based on that recommendation.
Brian, did you find any more of my typos?
Not offhand.
Okay, if there's no other discussion, I certainly can take a motion to approve this update to the education.
So moved, Brian.
Sharon Hollingworth seconds it.
Who was that seconded?
Sharon Hollingsworth.
Sharon did. Thank you both. All right, with that, we'll move to a vote. All in favor of accepting the updates to the formerly LVAD, now mechanical circulatory support education. Say aye.
Aye. Aye.
Aye.
Are there any opposed? Super, thank you. That item passes. The next one I have on the agenda is a standing item, which is just to review the training modules table and then discuss any additional trainings that people would be wanting to add to that. Charlie's pulling it up. I don't know. There it goes. So here's the overview to our trainings. I'll give folks a moment to think about it. If there's any additions or changes, we can discuss that as well. All right, if there aren't any discussion on that, we'll move to the next agenda item, which is to discuss the applied resuscitation education and specialized training. So this is my agenda item. So this is CPR and ACLS training program that we've developed at the University of Arizona as a pre-hospital specific education to certify in CPR and ACLS training. I have mentioned the previous training programs before. I think that we put a link on the DHS webpage to get to the website. And certainly any EMS agencies that are interested, we have done some train-the-trainer sessions for several Arizona agencies so far. And they are in the process of implementing it at their agency. So agencies apply to become their own training center, would go through a train-the-trainer session with our group, and would be able to deliver through their own training schedule, BLS and ACLS training, and receive cards that would they'd be able to use towards their state certification. If there are any questions, otherwise we can move on. The next one will be to discuss the current requirements for pediatric certification hours for paramedics and EMTs. So Gail, I'll let you kind of describe a little bit about what you and Chief Garcia have been talking about.
Okay. So, one of the things that we have been looking at are some trends and changes, and we recognize with COVID, everything went to virtual, and a lot of training kind of changed that model. We did have all the rule waivers in place that extended certification timeframes that allowed for a lot of different options for training. Those rule waivers have obviously all sunsetted, but I think as we kind of look into the next year, we recognize that people had in their certification cycle potentially a 12-month period where they may not have received a normal amount of training hours or training that was not necessarily kind of focused on anything besides COVID. I think everyone found their training was very COVID specific. So one of the things that kind of leads a little bit into G&H is looking at what are the current requirements for pediatric training within the state to maintain your certification. Arizona does have the 5 CE hour requirement for pediatric specific training. And are there any specific trends? One topic that I've heard brought forward was just the difficulty with for EMS to triage pediatric trauma patients, especially the young infants, so kind of the birth to 2-year age time, so pre-verbal age. And so kind of looking to see, is there potentially an opportunity and or appetite to look at some of these potential training gaps and figure out how we could do something at a statewide level? Certainly, as we develop these PowerPoints, the ones the Education Committee put together are excellent. I use them frequently to teach, but it does require someone to download them and then go out and administer that. Would there be a potential, if funding was available, to maybe create an online module that people would log into and be able to actually obtain training CE hours for that? So just wanted to start the conversation and kind of see if there's any identified training gaps that people have seen. The one that I've just noted that tends to come up periodically is pediatric trauma triage, especially in that pre-verbal age group, and just get some thoughts from the group.
So this would be a way for the DHS to support some of that distributive training where you wouldn't need an instructor necessarily. So it would be more online delivered, recorded and tracked, and then they'd be able to get a number of CE hours that way.
Potentially. So that would be one option. The other option is looking to work with a statewide stakeholder to help sponsor, if there's any funding, something like a 1-day seminar or even a 1 to 2 hour CE specific to something like pediatric trauma, and have that be something people can participate in. Anytime you do online training, you don't want to put all the resources in if people aren't going to participate, and recognizing that I think everyone is online meetinged out, but unfortunately, it's going to be the reality. I think a lot of agencies are kind of stuck utilizing that model as potentially their only model. And a lot of base hospitals are still not able to have non-employees come in to get those continuing education hours. So we wanted to just broach the subject, see, do you guys feel that there is a gap And if there is deemed to be a gap, what are some potential options that we could focus on?
Yeah, I have also seen there are some groups that have sponsored some free EMS recertification training across the country. So there's several groups that have put these on and they're available. So that would be one place to bridge the gap for those who are missing trainings, with coming up with a list of sort of acceptable or relatively high quality online EMS education to get BEs that is currently already in existence, with some of the waivers that have been and extensions that the NREMC has put in place. There's a lot of online stuff coming up. So maybe having someone go through and curate a list of other places that EMS agencies could go to get some of that distributed training.
This is Sandy. I can tell. I'm going to tout Chris Ramos's horn right now. PCH does pediatric training on a very regular basis for a very nominal fee, and I think that if he could make that available to even more people, perhaps posting it on the DHS website, that would be a very good option.
Yeah, this is Dale Woolridge in Tucson. I'll say second Sandy's theme there. Full disclosure, I come at this from the pediatric side, so I truly have a bias. I think the 5-hour requirement is insufficient in that our training is supposed to reinforce those things we don't necessarily have regular motor memory of. And our pediatric transports are rarer in that advocating training, I think, would be beneficial for all pre-hospital personnel. That being said, to extend on what Sandy was said, PCH, absolutely, a lot of resources. Northern Arizona EMS region puts on an annual conference. This last conference, they videotaped it and had been willing to allow that to be a shared resource. PACE's Pediatric Advisory Committee is supportive of this. We've been putting together some educational modules. So I think, again, extending on the comments, I think there's a lot of resources, and we can partner with not only the regions, but the individual referral hospitals like PCH, like Banner University, to be able to get that education put together. Absolutely, I think we would get a lot of good partners in the effort.
Dr. Woolridge and Sandy, this is Dave at the Bureau. I highly recommend that both of you send your information to Doug Cronk, our EMS education coordinator, about his website at the Bureau for upcoming CE opportunities. I think you greatly value that information put on the website. So he'll be your contact for that.
That'd be great. Thank you.
Dr. Rice is Orlando.
Potential for some funding.
Dr. Rice, this is Orlando.
I'm sorry, who was speaking online? We're having difficulty hearing you.
I think it was Orlando.
Can you guys hear me? It's Orlando.
Yeah.
So Dr. Rice, do you want us, or Dr. Bradley, do you want us to, the committee, to come up with a list of besides just pediatric trauma, do you want us to list of courses or continuing education or online stuff for our community to reach, tap into and use for continuing education?
I think the intent was to see if there exists a particular gap in training. So pediatrics was obviously one of the examples here, but is there a gap in which, if we had some funding, we could find a way to fill that training gap, and how that might occur?
Okay.
Hi, it's Brian.
Go ahead, Brian.
So I know on Northern Arizona EMS Council, we just got an amendment to our contract in the last few days, and it's going to have a $5,000. It looks like to each of the regions for EMSC money, and also as a part of the deliverables on that amendment is each region will have to do an assessment for pediatric training needs and so on. So maybe it would be good. I think Julia will probably end up with all that information to come back later and see if we gain any information out of that deliverable on the regions.
Thank you, Brian.
I think that's a good suggestion, Brian.
To answer the question about where I think the gaps might be, if we really had to go for the low-hanging fruit, I think trauma assessment, particularly pre-verbal child, as Dr. Bradley had mentioned, I think respiratory emergencies would be the other that I think would be high yield. Again, low-hanging fruit. Those are heavy-duty modules that I think have high yield and are more apt to be able to see those as far as pediatric EMS transports. So respiratory and trauma.
Thank you, Dale.
This is Chris Ramos. Can everybody hear me?
Yes, Chris.
I mean, according to NEMSIS data, seizures is one of the top reasons why EMS is called for kids, and some of the literature suggests that EMS really struggles with the administration and the recognition of seizures, and this is a problem at PCH. So I would hope that this would be a focus here at some point.
Yeah, excellent point, Chris. Dovetailing with the respiratory emergencies, kids get in trouble with seizures for respiratory reasons, particularly if they don't spontaneously resolve.
Thank you. Good. I think that's really the feedback we wanted to hear, is kind of trying to figure out where there are potential gaps and how we can move forward. Again, obviously there is some funding from EMS for Children that will go to the 4 regions, and definitely we can try to look and see how we can work with some of our external stakeholders to help support some of these trainings that are out there. So, thank you very much.
Perfect. Thank you all. That is obviously not a voting item, and that's the end of the agenda that I have for today. Are there any other agenda items anyone would like to bring for the next meeting? You can either let us know now, or you can contact Shelley Bissell and discuss getting those items on the next agenda. All right, next on the list would be a call to the public. Any announcements from anybody? If not, we'll go on to upcoming events. There are several on the list here. You can always go to the Bureau's News and Conferences page for upcoming events. The ones I have listed here are a free 4-hour virtual traffic incident management training course. So there's some dates listed there and registration links in the agenda. July 14th to 16th, there's the Western Pediatric Trauma Conference in Huntington Beach, and October 7th to the 8th is the Southwest Trauma and Acute Care Symposium, which will be virtual again this year. And our next meeting will be in November, same time. And with that, I will take a motion to adjourn.
So moved.
Second, Sandy.
Great. Thank you all for joining us today. We'll see you guys at the next meeting.
Thank you, everybody.
Thank you.